Good morning. I am Laura Wilkerson and nurse practitioner with Advanced Medical House Calls and Dementia Care Academy. I am here today to talk with you all about hospice, and I am so fortunate that I know so many good people who work in the industry of hospice, and I am blessed beyond measure to be bringing you my friend, Jennie Harter, today. So I am super excited, and I am glad that she agreed to join me, so I am going to bring her on. Good morning, Jennie.
Good morning, Laura. How are you today?
I am awesome. How about yourself?
Good, thanks.
Thank you so much for coming on and joining, me and my viewers today. I'm so excited that you could take that time with us.
Oh, it's an honor, really.
Yeah, thanks. And thanks for taking time out of your morning. Hospice is a really, really delicate subject. So many people have so many questions. And this last week, I probably had 20 or 30 people reaching out and asking me different questions about hospice. And I couldn't think of anybody better to join me than you, because you and I have worked so closely together. And there are so many times that I lean into you, for that understanding. And I know our philosophies align. And there are times where we meet people and sometimes they're not ready or they have a lot of questions,
Right.
And answering those before they make that decision is very important.
Right.
Even for myself, I had that crossroad. But before we go into that, tell us a little bit about yourself, where you're from, where you were born and raised, and how did you choose hospice?
Well, I grew up in Detroit, Michigan, and when I went on to nursing school, it was much later in life. I had 3 kids already. And I decided during nursing school, when we were doing some of our rotations, one of the classes that came up was hospice. And my grandma was actually going through hospice at the time. And it just kind of touched my heart in a way that I can't even explain. It's like I knew at that moment that that's what I wanted to do. And I was fortunate enough right out of nursing school to obtain a job in a hospital setting on a hospice and palliative care floor. So my first experience as a nurse was hospice, and I've done some other things while working in hospice, but it always comes back to hospice. It's a level of care that is very important, and I felt that the dignity and quality of life is something that you can't take back. You have one chance to get it right, and we only get one journey in this life, and we want to make it the best that it can be.
Absolutely. And I would agree with that 100%. I think everybody that is in the healthcare field sort of has that same epiphany moment where you know what you want to do and you don't know what you want to do.
Right.
And I think for me, it was, I know what I don't know what I want to do now. I just need to find my passion. And certainly, helping those who are aged and at those points in their life where those crucial decisions need to be made. I love helping people navigate that journey. And I think that's what it's about. There is a time for me. That time was being a nurse practitioner and doing house calls and caring for my grandma. I cared for her, after her stroke. And she had vascular dementia. She had aphasia. She had difficulty talking. And I know there are a lot of people out there that I've met with that are in those same situations. And I was caring for her medically, not physically. She lived with my mom. But there came a point in time and she was, declining. And it was evident that she was declining. But I was under the impression that if I, talked to her about hospice, that she was going to give up. If I told her that I needed to take a step back medically, that she was going to think that I was giving up on her. And there was, not only that conversation, but I also had to have the conversation with my mother, and say, these are the things that I'm noticing, and these are the things that I think could be beneficial. I can't provide all of those services as much as I want to. And I think I need to take a step back. And it was tough. man, it was the toughest decision ever. One, to have the conversation with my grandma,
Mm-hmm.
and two, to have it with my family, not just my mom, but she has siblings as well.
Right.
And so to help them understand that we weren't giving up, but that there was actually some benefits,
Right.
and that people actually can thrive on hospice, which seems really contradictory. Most people consider hospice end of life.
Right.
And
Right.
they think, we're done, this is it,
Right.
and they actually thrive. Good morning, Debbie. Thank you for joining this morning. Glad you're here. Debbie is a good friend of ours, and she recently had experience with both of her parents going on hospice and having that whole experience with hospice. So I appreciate her joining this morning. I know she's got some perspectives herself on hospice. And good morning, Joni. So it was a tough decision for me. It was a tough decision for my family, but honestly, hospice was a huge benefit to my grandmother and to her family.
Right.
There are lots of people out there who struggle with that. Jennie, how would you talk to them about that struggle of being a family member and explaining that hospice benefit versus an end of life choice?
That's a good question. And it's something that I do every single day. So in talking with families, it's hard to make the decision because, again, they feel like if they make that decision, that they're giving up on their loved one. And we need to change our train of thought with that and our thinking patterns, because in reality, what's happening is their bodies are giving up. Their bodies aren't working anymore. Things are shutting down. Their appetite might be decreased. They might be having trouble swallowing. They may be going back and forth to the hospital. And we can get into more and more of that as we go through our conversation, but there are so many key things that come up: weight loss, increased sleeping. We call that energy conserving. There's so many different aspects that we look at. And when having that conversation with families, when they understand what the body's process is doing, and when they understand that hospice allows the body processes to shut down in a natural way, and what hospice does is help manage the symptoms associated with the natural process. And we're not going to interfere with that process and just allow the body to do what it knows exactly how to do. And we don't give it enough credit for. Sometimes having that information and understanding that helps them realize that they're not giving up on their loved one, or their loved one's not giving up. Their bodies are giving up, and modern medicine can't even fix it. They've been treated optimally. Things have been changed around. Medications aren't working. Blood pressure's still high, or their swelling and edema is very high. There's increased shortness of breath. It depending on what their disease process is. By talking about that, it helps them understand that, oh, the body's doing what it's supposed to be doing, and we're kind of, and I don't want to say interfering with that, for lack of a better word, we're kind of interrupting that and maybe sending them to the hospital and maybe rehydrating, or it could be back and forth. And then we have to stop and think, what are our goals for our loved ones as they get closer to the end of their journey? What did the loved one explain how they wanted it to go? Do they want to go back and forth to the hospital? Do they want to have surgery? Do they want to have medical interventions? And what are their doctors saying? The conversations sometimes are even hard for physicians. They have a hard time bringing it up because they sometimes have misconceptions about hospice. And so many times people come on so late because of that fear, when in reality, if they meet criteria through Medicare guidelines, they're eligible for the benefit. And while that means we can't seek aggressive treatments and, keep sending them back to the hospital and to rehabs and things like that, we allow that process to happen naturally. And by doing so, many times people improve for a little bit. Their symptoms are better managed. their quality of life improves. They're able to have the difficult conversations with family members with help sometimes from social work or spiritual care, end of life review, going through their life and feeling more at peace with what's happening. So all those disciplines are coming together to treat not just the physical person, but the spiritual and psychosocial as well.
Absolutely. I want to say good morning to Ken. He's a very good friend of mine as well. Good morning, Ken, and thanks for joining this morning. You know, my philosophy on hospice was not a good one. I mean, quite honestly, I thought I could save everyone. And so again, even with the patients in my private practice, that conversation was difficult.
Right.
And it's no secret, I worked with hospice for quite some time to better myself for my practice, for the patients, for the families, because I also had misconceptions. And it wasn't until really getting into hospice and getting to follow that philosophy of care that I came to understand.
Mm-hmm.
You know, Joni joined us this morning and she actually reached out and she said, I just want to say, I hope you're recovering. I hope she's in her recovery stages. She's not feeling well. She actually is sick with COVID. So praying for you, hoping that you're on the mend. But her mom actually fell in and had broken her hip. And so her mom went and had surgical repair. You know, she's not walked since, and she hasn't seen her mom because her mom is in rehab. Her mom's in a nursing home and she's rehabbing. So she hasn't been able to physically lay eyes on her mom. And I know, and you know, that COVID has been one of the toughest times that we have been through. I don't care what your philosophies are on hospice, to mask, to not mask. It's a pandemic. It's whatever. I'm telling you right now, from my experience, the elderly are our vulnerable population. And we know that we have to mask up when we go in to see them. We can't not. We have an obligation to them and to protect them. So it's been a rough and rocky couple of months for us, you know, having those difficult conversations and having lots of hospice talk conversation. But her mom is in a nursing home. She can't see her. She said that her mom has gone from 140 pounds down to 110.
Okay.
And she said, I'm not even really sure what I can do. She's like, I can't go there now. She said, but how do I know when it's the right time? How do I know? Because I can't see her. I don't know what's happening. I just am going by their word of mouth. Is my mom appropriate? Can she have an evaluation in that rehab center? Do I do it from the facility? How do I even go about getting my mom the care that I think that she needs if she's appropriate?
That's a really common problem that happens with our elderly population, the broken hip. And I'm just it's the elephant in the room. It's the broken hip. It's a very serious problem. When they fall and their bones are more brittle and something like that happens, their risk of not recovering from that is very high. It's much higher than most people realize. So when that happens and they're in a skilled nursing facility, and, you know, we can't get in there. A lot of hospice staff can't get in there. So the nurses can go in, the aides can go in, but they're really, really careful on who else goes in with good reason. There's no right answer about how to allow families in or not to allow families in. I want families to go in, but I don't want them to get sick. So where's the balance, right? So I wish we had a magic answer for that. When they become bedbound after a broken hip, we start to sometimes see other things happening because of that, whether it's they're not eating, their weight loss. You know, that's a very big weight loss. That's more than 20% of her body weight. And that's since February. So we're talking, 8 months?
Yep.
That alone as a hospice nurse is a red flag for me. Because with hospice criteria and eligibility, we're looking at 10% of weight loss within 6 months. So that's more than 20%. So that's pretty significant. What I would do is speak with the physician at the facility, let them know your concerns, and you can request that the doctor kind of consider writing a hospice order to evaluate and admit if appropriate. She can be evaluated in the skilled nursing facility. There becomes a difference, and I don't know enough, but I know enough to get my mouth in trouble. So I'm just going to say there's a difference when people go on to hospice as to whether Medicare would pay for their rehab stay or if it needs to be private pay once hospice comes on board. So you need to check there, because sometimes that's a shock for families.
Sure.
That it's not, the room and board is not covered by hospice. So
but hospice is covered, correct?
Hospice is covered by Medicare, 100%, no copay, no deductible, and it's an umbrella that covers the team of people going to see her, which would consist of a nurse case manager, an aide to do some additional personal care. You've got access to social work, chaplain, maybe even additional therapies, music therapy, massage therapy. Some have pet therapy. So we're treating again, looking for lots of different avenues to treat that whole person and meet them where they're at in their disease process. So when someone goes into a skilled nursing facility thinking they're going to rehab and come out, and that doesn't typically happen, maybe they're not, they can no longer take care of themselves. They can't do their activities of daily living. Maybe they can't feed themselves, or maybe they've forgotten how to feed themselves. All of those things are red flags showing that there's something going on. There's a decline happening. Mm-hmm. Do they meet hospice criteria? That will depend. It all comes down to the evaluation. And in order to have that done, we have to request that from their physician. And typically that comes from the primary care physician or the physician in the rehab or facility where they reside.
A couple of questions came to mind when and they're questions that were asked, but while you were talking, number one, so the order has to come from a physician, but what if I'm a family member out there in the community and I want my mom availed, but the physician is kind of maybe not paying attention to my words? Can I contact a hospice facility? Can I contact a hospice organization and ask them to go in and evaluate? And can you?
That is a very good question, and it's a very sticky area. Okay. So you can always call a hospice company and have an informational. Okay. Once that, and here's how I would handle that situation. So what I would do is I would collect as much data from the family to determine, how does this look? Do they look like they may meet criteria? Are they nowhere near meeting criteria? Sometimes you can find a lot of that out from a conversation. If we need more information, we can request medical records and then take a look at those. And then what I would do is I would call, if I feel that this family deserves and this patient really deserves that eval, I would personally call that physician and plead the case for the patient. I have no problem calling and having my list of concerns there so that I can express that to the physician. There have been times when they blatantly refuse to write the order, depending on what's going on with that physician. There are a couple different avenues people can try, but realistically, the primary care, we need to give them that respect and that time to at least complete our case before we explore other avenues. Sometimes a specialist, but it really depends on the situation. And, we have to follow the rules. We have to do we have to meet the requirements, and we have to follow the rules.
Yes. Which leads to, I think it's really important to know that the criteria for every different diagnosis, because hospice just isn't cancer. It's not just dementia. There are other diagnoses that are applicable to being admitted onto hospice. And although Jennie and I would both love to to dive into all of those individually, there is certain criteria that people have to meet. You know, weight loss, we've been talking about weight loss and bedridden and things like that, but every diagnosis has specific criteria. So what might meet for, you know, Parkinson's might not be the same criteria to admit somebody for dementia. There are very different criteria, and they all have to be looked at as not as individual diseases, but as a holistic person. You can't just take one thing and run with that one thing, which leads me back to weight loss. What if my person cannot walk, Jennie, and I can't get them on the scale? What am I going to do with them if I, you know, like I can, like they're losing weight, I know it, but how do I convey that if I can't put that person on the scale?
You know, the best way to do that, you're going to be, if you're the caregiver, you're looking, you know, if you're helping them shower, helping them get dressed, you're seeing changes, not just in how their clothes fit, but you might be seeing, you know, some sagging skin. You might be seeing the bony prominences protruding. I always look here, right here at the clavicles here, because when those really start protruding and they really weren't there before, those are the ones you see. The shirts start hanging off the shoulder. I will sometimes ask a family, okay, what size did she wear a year ago? What size does she wear now? And they may not know the exact size, but for instance, I had somebody yesterday, she wore a 2X a year ago and the mediums are too big. That's a huge, significant change. You know, a size, a half a size, but when you see multiple sizes within 6 months to a year, we're looking at a very significant weight loss. And sometimes it would require a lab draw from their primary care doctor. Sometimes they have that lab draw. We're looking at their protein, we're looking at their albumin to kind of see, they may have a trend so we can see that it's declining. It might not be exactly the number it needs to be for hospice, but it's declined so rapidly. And maybe that person has another comorbidity that goes along with it that's starting to exacerbate. So we're looking at not just one diagnosis, but everything that pertains to that and any other significant history that they have.
Yeah. So speaking of conversations and knowing, you know, the weight loss and everything like that, I had a great conversation yesterday with somebody, and her husband lives in an assisted living facility. And the conversation unfortunately had to be over the phone, but basically lots of falls, super low pressure. And so I had the tough conversation. I'm very comfortable having that tough conversation. I don't like to have it over the phone, but
no, I know.
You know,
we're very challenged in these times with these conversations.
Absolutely. And you know, I'm a hugger, so it was super hard. I couldn't get to the person on the other end of the phone. So we were talking, and I basically had to have that conversation where if it's me and you, and if it's me and your loved one in the room, and they were to drop to the floor and their heart were to stop, what would he want me to do? Am I going to start CPR? Am I going to start, you know, rescue breathing for your person? And she paused for a minute and had to think about that for a second. And she said, well, that's what I'd like you to do. She said, but I know that's not what he wants. And I said, well, great. Then why don't we respect his wishes, and why don't we have hospice go in and evaluate? And she said, well, he does have dementia, but he's got just that little bit of no, where I don't want the hospice people walking in his room and saying, hi, I'm Jennie from hospice and I'm here to see you today, you know, because I don't want him to think that I'm giving up on him, because he knows his parents, you know, passed on hospice. He knows what that is. So what do you do in that situation? Or how would you explain to me if I were a family member and I'm like, you can come in and see my grandma, but you can't, I don't want her to know that you're with hospice.
Well, and you know, that's a really tough question. And it's very tough because the first time someone asked me to do that, I kind of looked at them funny, like, how am I going to do that? So what typically would happen is we would just suggest to our staff to avoid using the actual word hospice and use comfort care. So right. Because comfort care is hospice, right? Mm-hmm. So, but we also have to explain to our families that Medicare requires that we wear our badge, our name badge, and on the badge, Yep. And I have my
big letters.
Yeah. But I always have my name badge, and it says Jennifer Harter, RN, hospice. And if they're able to see it, which many times our dementia patients aren't able to quite see that close, because it's not, my shirt's easy to read, but some of our uniforms say hospice on them.
Sure.
So we're not going to lie if they ask, but we will certainly do our best to use the word comfort care to respect that. Hospice has a stigma, and I really wish it didn't have such a stigma. And what people don't understand is hospice is a fairly new type of medicine in the United States. I mean, it was in the 80s when Medicare started paying for it, right? So back then, you literally used hospice for the last hours.
Yeah.
And then it slowly progressed. And over time, hospice has expanded. The benefit has expanded. There's so much available to our patients when they meet that criteria. When they meet that criteria, they are eligible for the benefit. They can take it. They don't have to take it, but they're eligible for it. And it does help with costs of medications. It helps with cost of incontinence supplies, durable medical equipment, and of course that team of people, like I mentioned earlier, to help with that plan of care. So they're treating the whole person. So, there is a lot of cost savings there for the family. They see their pharmacy bill go down a little bit, maybe not all the way, but a little bit, as long as it's, related to their hospice diagnosis and their comfort. We're going to pay for those medications. So, and we're not just going to stop their medications because they come on hospice. That's another huge misconception.
I was just going to ask you that.
Here, and they've been on blood pressure meds, you stop their blood pressure meds, they're going to go up. If their blood pressure is starting to do this, we're watching that. So, for example, blood pressure medicine is a good example. So if their blood pressure is starting to really go down as their decline continues, maybe their weight's coming off more, they're not eating as much, their heart's not pumping as well. There's a lot going on, right? So when that blood pressure starts to go down, we may then adjust the order. We may change the dose that they're getting. We may put what's called a parameter, so that they have to have their blood pressure taken in the morning. And if it's under a certain number, we're not giving that medication that day. And then if we do that parameter for so many days and they're not getting those blood pressure meds, we're going to stop those meds, because it's more important to keep that blood pressure here rather than it tank. If that blood pressure tanks, we're in trouble.
I think a lot of people don't know that too, that, they see the front. Mm-hmm. But then there's also a behind the scenes in caring for somebody with hospice. And when your loved one is in a facility, whether it be rehab or skilled nursing or an assisted living, there's lots of things that we as medical professionals, and you said it, you said parameters. Yeah. I'm a huge parameter person. It is parameters, meaning, let's say you're taking a blood pressure medication, or your person's taking a blood pressure medication, and they took it when they were younger, and they were taking it when they were maybe a little bit heavier, maybe eating a lot of salt on their food, and they weren't exercising physically. And so their blood pressure was sky high. And when their blood pressure is sky high, they needed those blood pressure pills. Mm-hmm. But now their weight is, dropped, and they're no longer eating the way that they used to because they have no control over their own diet. So I put parameters there basically that say, if their blood pressure is between this and this, we don't need to be giving that medication. And it's because I'm starting to see those declines that I know now to look for as a clinician.
Right.
And I try to convey to the families every time why I put these things in place, but sometimes I get busy. And that conversation, because there's other things that are important, that piece, that little bit that you just talked about, fails to come through.
Right.
And there's reasons we don't want them bottoming out, like you said, because it's going to cause them to fall. It's going to cause them to have issues of dizziness, where it puts them at risk for other things.
Right.
Sometimes we forget to convey that information. And so then we consult with hospice. Right. I'll consult with you and say, I think it's time. I'm seeing these changes.
Right.
And then it looks like hospice comes in and takes away all these meds. And then next thing you know, my mom is dying. They started the morphine and took away all of her medications, and now she's dead, or they overdosed her on morphine. I know a lot of people have that concern, Jennie. How, I mean, other than over communicating, which I know we both try, and I know family members try as well. And I always say, ask. If I don't think to say it and you've got a question, please make sure to ask.
Right.
There's no dumb question.
No. And the morphine is the biggest misconception. So I'm going to tell you, I felt the same way. I was in my early 20s when my mom's mom had cancer and she was on hospice. And I remember vividly the conversation when they said, oh, well, they started the morphine. And I was like, okay. And that to me meant, okay, that's it. The morphine's going to kill her. Right. And she did pass away a few days later, very comfortable. And I was just talking about her the other day because I remember how comfortable she was. And she looked over at the window and she said, do you see the angels? They're there. And I thought, what? And it's going to bring me to tears just thinking about it.
Yeah, I know, me too.
I knew that they were coming for her. And that's what she needed with her strong Catholic faith. She was ready to go. She was okay with it. And she was still able to talk to us. She was still able to do those things, but she was comfortable. Her respirations were under control. She wasn't short of breath. She didn't have the pain when they were moving her and turning her and changing her. But in my mind, back then, the morphine was it. It was the morphine. So what I like to explain to our caregivers is helping them understand that when hospice comes in, they're considered to have a terminal diagnosis, okay? Whether that means, typically, if we allow that natural process, we would expect that they would pass away within a 6-month time frame. Now, that's just based on that evaluation. There are so many people that live well beyond those 6 months. 1 year, 2 years, 3 years, 4 years. We don't have a magic ball. We don't know. Mm-hmm. But sometimes we get those symptoms managed and they do better and they kind of taper off. And sometimes they're discharged. They graduate from hospice. So that's not such a bad thing. And it happens. It happens more often than people think. It doesn't happen all the time, but it does happen. So going on to the morphine, what happens is they come on with this admitting diagnosis. And I'm going to use congestive heart failure as an example, because it's a very common one. And it's easy to visualize when I explain it, okay? So they may come on with some congestive heart failure. They're having some shortness of breath, even just having a conversation, or if they're eating, they really are struggling to breathe in between bites of food. It takes them a minute to recover. These are things most people wouldn't think to look at, but when I walk into a room, that's the first thing I would notice. Or if they're trying to speak to me and they have to like take a breath in between a couple words and take a few breaths, same with COPD. So we can kind of simultaneously use those because that shortness of breath can come into play with both. So that diagnosis is showing us, congestive heart failure might be showing us swelling in the lower extremities. Their ankles are very large. They're taking maybe a diuretic like Lasix or something to kind of pull some of that fluid off. But the heart, when it was good and healthy, it was pumping really well, right? And now with this congestive heart failure, it's kind of being squeezed, right, from the outside. So it's kind of pumping like this. So it's got to pump a little faster because it's trying to get blood where it needs to go, but it's not strong enough to pull that fluid off. So despite all of our interventions, it's not working. So maybe they're coming onto hospice, okay? They come onto hospice and maybe in a few weeks, they're really short of breath. So maybe we're going to start some oxygen so that they can feel more comfortable. And knowing that oxygen is going in reduces that panic for them. They don't have to use it, but realistically, it's a comfort measure to make them feel comfortable. If they like it, great. If they don't want to wear it, that's their prerogative.
Yeah, okay? You could consider it part of the comfort pack. I mean, literally, oxygen is just like the comfort pack. Comfort pack meaning those medications that people are often so scared of or afraid of, which is the morphines and the Ativans and stuff like that. Oxygen is a comfort med, a comfort measure.
Right. So we might start oxygen, and then they do okay for a few weeks, maybe a few months. And then all of a sudden we start to see that real decline. They're getting really weak. They're not swallowing well. They're coughing with liquids. Okay. Maybe coughing when they're eating. And now they're getting really short of breath. Maybe their respirations are really fast. Okay. Mm-hmm. And the only way to explain that is to try to breathe really fast for a minute. And I guarantee you get to 30 seconds and you're dizzy. So imagine how that person is feeling trying to, get the oxygen that the body's trying to get. So it's breathing faster and faster. That's when we may bring in some morphine. And people look at you and go, morphine? Isn't that for pain? Well, of course it is, but it's also for shortness of breath because it allows the body to get the oxygen demand it's trying to get without having to work so hard to get it. So it kind of relaxes that breathing so that they can actually absorb the oxygen and that gas exchange can happen in the lungs, right? So You might see those respirations go down and now, wow, look, he can sit at the table and have a meal with you because he's able to get through that meal, or he's able to talk to you, or he's able to go outside or go somewhere with the family that without that morphine, he just wouldn't have the energy to do it because his body's working so hard just to breathe.
Mm-hmm. So, and I think that's difficult because families see their person get better. Yeah. And it's an improvement because they're not right. Or their heart's not, you can't see a heartbeat physically depending on somebody's, body habitus, but that heart also on the inside. So you might see this, you might see them upheaving with their shoulders or their chest, but what you're not seeing is you're not seeing that heart beating. And I'm here to tell you, your heart can only beat against that resistance, that fluid resistance for so long before it's going to say, I'm done with this. I'm done. I'm absolutely done.
And so many times when that decline is happening, people don't realize they are going to pass with or without the morphine. They're on their way. Okay. So when those symptoms happen, they're on their way. So that terminal diagnosis happens. We might add oxygen. We might start morphine. So every little while we might be changing some things. And then all of a sudden they can't swallow and they're really not waking up much. And people are thinking, well, they gave him morphine 3 days ago because he couldn't breathe. That's why they gave the morphine. They didn't give the morphine because he's on hospice. They gave the morphine because the symptoms arose from the natural process of shutting down. We're there to control the symptoms of that, and shortness of breath or, pain or inability to swallow. There's so many different symptoms that come along with that. So that morphine's coming in when the symptoms arise. And I'm going to tell you, as a nurse, I remember, and I'll never forget, the first patient that came to our floor and the family refused to let us give morphine. And I watched that person suffer. And I said, this will never happen again on my watch. I need to be able to educate and advocate more. And it didn't matter what anybody said. They felt the morphine was going to kill the patient. And I just didn't understand. I mean, I understood what they were saying, but if you ever see it or watch it, it just is not, it's not comfortable.
No, it's not. And that's called a bad death.
We're asking for. That's called a bad death.
That's a bad death. And I agree with you. There is, if you've seen one, you never want to see it again. And I know I have discussed this thousands, pardon me, of times with families, when they get to that point where they're like, I don't want the morphine added. I don't want the Ativan added. You do. And I educate and say, there are good and bad deaths, and what end of life is supposed to be peaceful.
Right.
And you can, I don't know, like you said, I don't have a crystal ball. I don't know what end of life is going to look like for your person, but what you don't want is you don't want the meds to not be there.
Right.
Because the struggle, this is a cliche, the struggle is real.
It is. And most hospices have what's called a comfort pack. Okay. So that would consist of a medication like morphine, unless they have a contraindication to morphine. Typically, morphine is what's used the most. They may have something for agitation or restlessness, which is a true symptom of end of life. We call it terminal restlessness. So they might be trying to climb out of bed. They might be grabbing at things in the air. They may be falling, getting up, forgetting they can't walk, getting up and falling, getting up and falling. They may be just kind of moving around in the bed and not really responding. There's so many types of terminal restlessness, ways for them to exhibit that. But that will help relax them. We have something sometime we use for terminal congestion. So when they can no longer cough or clear their throat and you hear fluid kind of building up in there, we do use medication to kind of dry that up a little bit, so that it really sounds horrible sometimes. So we try to help with that. We use many times things for bowels in our comfort packs, because when we start an opioid medication, they can get opioid-induced constipation. And with our elderly population, they're already fixated on their bowels. And it's one way or the other, okay? Very few are just fine. So we've got one way or the other. So they're always worried about that. And the last thing we want to do is add something that's going to make it more difficult for them to go to the bathroom. So we do typically include that as well. A Tylenol or some sort of a mild pain reliever or fever reducer or something like that. So just kind of putting those things together. So if and when they need them, they're there. If they never need them and they go to sleep and you wake up in the morning and
Beautiful.
they didn't.
Beautiful.
Absolutely. Realistically, that's not typical. We can always hope. I mean, that's how I'd like it to go for me personally. So, but to know that it's there and available if and when it's needed from the very beginning is very important, because when a crisis happens, you don't realize what you needed until you need it.
Yeah. And it's not easy to get those things at 2:00 in the morning.
Correct.
I mean, we try to have that happen. I've been called in the middle of the night and woke, and we try as hard as we can.
And find a 24-hour pharmacy, and you're right. We can do it, but how long and at what expense for the patient
or the family?
Watch.
That's the bad death right there. That is the bad death experience. Yeah. I know there were some other questions that I really want to get to, because they came up a lot. And one of them, Jennie, was, do I have to be homebound?
No, of course not. We actually have hospice patients that are still driving. They have a terminal diagnosis that is, we expect them to not be here in 6 months. Typically, they're not driving for a long period of time, but as long as they're able and their mind is all there, we have people, they're leaving the house, they're taking a vacation, they're going with family to the other side of the state. That happens all the time. It's about their quality of life. If they meet criteria, they're eligible for the benefit.
Which is beautiful. And I think that relates to the next question is, my person has a diagnosis. They're not necessarily terminal right now. I'm kind of on that line, and if they're not dying right now, like they're physically not in that bed dying, is my person still eligible?
Absolutely. And again, it all comes down to that evaluation that's done by the nurse that comes out initially to determine, based on the medical history and what we're seeing now, yes or no, they do or they do not meet criteria. It really comes down to that evaluation. But again, if they meet criteria, that typically means they have a 6-month time frame if we allow the natural process to take its course. Okay. Many people live beyond that. Many people live less than that. Okay. It varies, but the studies are finding that people live an average of 2 months longer when they have hospice on time. And I believe that's because there's lots of factors, but in my experience, they're not going to the hospital. They're not picking up secondary infections in the hospital, right? Yes. When they go to the hospital and they're not up and moving around, then they need rehab, and then they So it's just this vicious cycle that just keeps going around. For some, it isn't. For others, it's back and forth, back and forth, back and forth. So when they meet that criteria, they could still have 1.5 years, 2 years left. Again, they could graduate hospice. And one of the things that a lot of people don't realize is people have a right to change their mind. So if they're on hospice, let's say they're on hospice 3 or 4 months, and something happens, something out of the ordinary happens, and they want to seek aggressive treatment for their loved one, they have every right to do that. They have every right to revoke those services and seek whatever treatment they need to seek. The important thing is that they revoke those hospice services so that they can seek those aggressive treatments, because the last thing any of us wants is for a family to get a bill from the hospital for aggressive treatment because they didn't revoke those services first.
Because hospice couldn't cover them, you mean?
Correct. Okay. And it would be something that, when hospice comes in, there are very few instances we're going to send someone to the hospital. Uncontrolled symptoms, we can contract with that hospital and keep their hospice services going. That's called a general inpatient level of care. Very rare, but it is available. The respite, that's another thing that I wanted to really quickly touch base on, because so many times people need extra help in the house when their loved one is living with them. Hospice does offer a respite, which gives them 5 days in a skilled nursing facility for their loved one. So maybe they need to attend a family wedding. Maybe they just need a mental break. Caregiver burnout is real. And I think it's undertreated. So it's important for them to know that that is part of the hospice benefit as well, getting that extra support and extra care.
No matter what, Jennie, no matter what your insurance is, no matter what, everybody.
No matter what.
Wow.
Respite is available for hospice. It's part of the hospice benefit. It is available. It's a 5-day respite. And the social worker and the nurse and, the administrators, they all help
the team
get that in place for the family with transportation to and from when they're on hospice. Yes.
That is amazing. As many years as I've been doing what I do, I'm not even necessarily sure that I knew that. I knew some insurances provided respite as
that's a hospice benefit. Yep.
Wow.
Yep.
That's pretty amazing. So for those of you who are watching, I know that there was questions about, who I could have and what I was entitled to. I think that is something that really needs to be reiterated if you're needing that break, if you're burning out, and sometimes after years and years, because the average patient with dementia, Parkinson's, and such can live 20 plus years. There's going to be a time where you need a break. And if your person is on hospice, I think that's something worth looking into. I see that Pam here says that she has respite for 5 hours on Wednesdays. Does that take away from her benefit if she chose to go see a family member in another state? If she has respite
I don't know. That's a good question. I'm not sure exactly how that was organized with her hospice, but we do also have volunteers. So there could be, the volunteers can come and stay sometimes with a family, your loved one, while the caregiver goes grocery shopping or goes to get their hair done or something like that. The difference is that volunteer can't actually do care, but they can be there if there's an emergency and they can place calls.
Supervision.
Yeah, and that could be part of what she's getting. Or I don't have an answer to that. I don't know.
Sure. Rosemary is a wonderful person. I know she's been following me for some time, and I know that I believe she had an experience with hospice not terribly too long ago, and I value her opinion when she hops on and what she has to say. So, Rosemary, thank you for joining this morning. A couple last things that I want to make sure to hit on for people. They were talking about like supplies and stuff like that, and I know you had mentioned that as well. So they're eligible for things like undergarments and Chuck's pads and stuff like that. Is that something that hospice delivers right to them, or does it come to their doorstep? How does that typically work for a family member?
Varies from hospice company to hospice company. But what we do is we order them in 2-week increments, and we have them shipped directly to our patients' homes, wherever home is. That's where hospice takes place, right? So that would be briefs, pads, pull-ups, wipes. the disposable pads for the bed or the chair, maybe some barrier cream, wound care supplies and wound care if your loved one has, God forbid, a wound or something that needs to be dressed. We do train caregivers to dress, but hospice does typically take care and manage that wound care as well. So there are times when we would order an antibiotic if there's a treatable infection going on. Many times hospice will treat that infection, whether it's a urinary tract or upper respiratory, but we're treating it with oral medications typically. And because the nurse is going to see that person, they're able to sometimes get a head start that something that may have gone a few extra days and gotten much, much worse, typically we can get under control pretty quickly.
What about, and I want to be respectful of your time here. I know you've got a busy day today. What about therapy? That's a really big concern. Oftentimes patients that are, borderline, families are like, I don't know which way to go with this. We'll be on physical therapy, but then there's that need for hospice.
Right.
What happens for a person who wants physical therapy? What happens for that person? Do they get to keep their therapy in hospice?
That's a good question. And typically what happens is they've exhausted their therapy and they have met their new norm. Okay, so whatever that is, they've plateaued in therapy. And that's a lot of times when we get called. Okay, so typically Medicare is not going to pay for physical therapy and hospice at the same time. Therapy is considered aggressive treatment, where hospice is considered comfort care. So I'm not saying there aren't exceptions to that rule. For example, let's say someone is newly bedbound and just had some sort of surgery, and the caregiver in the home has to be trained how to transfer and how to do certain things. A lot of times they may cover a few visits for that to happen, but that again is a case-by-case basis. And we always want to make sure that so many times physical therapy is coming in, and talk to your therapist. How is she doing? Is she getting better? Is she getting stronger? Is she participating? Because many times they don't want it. They're kind of
want it,
doing the minimal and not really doing a lot, but doing enough for them to keep coming. Every situation is very different, but simultaneously, typically, no. We're not doing that.
And I think a lot of times if we really look at it, sometimes it's our own true feelings. I have that discussion with families a lot. I know that you want therapy, but your mom doesn't, and she's telling me so. So you might want therapy because you think it's what's good for her, but she absolutely is like, I'm not doing this anymore.
Right.
So sometimes it's about realizing where a person needs that break, where they need to relax, and where they need to let that natural process start to happen. They've already accepted on the inside that they're not going to walk again, or that they're not going to be reaching above their head anymore. So to really be respectful and to have that conversation with your person is really super important before you can't have that conversation. I always say it's never too early to start having crucial conversations, which, again, I just want to reiterate to everybody, it is never too early for a hospice to have hospice come in and evaluate. I've had plenty of times where I've said to Jennie, I'm not really certain that this person is going to qualify. So even before I start the conversation with family, here's what's happening. And then if she's like, yeah, I think that I think that this might work, I'll go to the family and we'll talk. But then once Jennie actually lays eyes on, it's two sets of eyes, and maybe that criteria isn't there, that Medicare criteria isn't there. But I don't think that it's ever too early, because you know what that beginning baseline is. So you've seen them here, and now you're going to see them over here when, maybe it's 2 weeks, maybe it's 2 days.
Yep.
So I think it's always important to have an evaluation. And then if you're going to have them reevaluated in a couple months, stick with that same hospice agency, because they've seen
they have a
both sides where they were. And that's important, because they'll be able to see that decline because they took notes on that. So I think that that's really super important. I just want to check over here and make sure. Oh yeah. Thank you for that. So I think, is there anything else, Jennie, that you can think of off the top of your head that might benefit everybody on their hospice journey or their journey with their person with dementia or Alzheimer's or Parkinson's or even terminal cancer? I know that there's people who, probably are watching this for different reasons than dementia. Is there anything else that you can think of?
Well, I'd like to leave it kind of with this. And it's because sometimes we have to take a step back and really think about what our loved one may want if they're unable to tell you. We have one journey in life. We get one. We don't get to redo it. And as our bodies start to slow, what do we want that journey to look like? So it's very hard sometimes to come to those conclusions because we have to face things we don't even want to think about. Whether it's a parent, a grandparent, a next door neighbor that you're in charge of their care, it doesn't matter who it is. This is not an easy decision. It is something that is worth putting thought into and getting as much information as you can. You don't have to have an order to get information. Number one. So getting the information ahead of time helps so that when that decline happens and maybe they approach you about hospice, you don't feel like you're making a decision under duress. So the sooner you get the information, the better. And again, we have one journey, one shot, and we want to get it right. And with hospice, we have to get it right because we're the ones helping and being a part of that journey. So we're honored to be able to do that for our patients, and anybody working in hospice, I can speak for all of us. This is a passion. This is something that we can't explain. People say, how do you do this every day? I can't explain it, but I know that this is where I need to be. So, and I feel like all of us in this industry and in hospice, especially with end of life, we're here because we want to be here.
Absolutely. And we want that. We want that good death experience. We want it for the person that we're treating. And actually, when you're treating a person, you're treating the whole family.
Right.
And that person almost becomes part of your heart family because you've spent so much time with them and on their one journey. Mm-hmm. And I think that that's important to now start having those conversations. I gotta hit it before we part each other's ways, because it's coming up over here in my comments. COVID, none of us expected COVID.
Yeah.
And it blew a lot of our minds and blew us out of the water. And so we don't know what the fall is going to bring.
Right.
And a lot of our patients were living in assisted living facilities. Excuse me. And so there's been the question of, well, do I pull my person from a senior living? Do I pull them from the place where they live in an assisted living? And my answer to that is going to be no. You're pulling them from their home. You wouldn't go pull them out of their private home and yank them into your house with you. And honestly, if you're still working and you're out there in the community and you have children or visitors, you're putting them at more risk. Correct.
Right.
But if a person gets COVID in the fall, if they are one of the people who get COVID and it's affected them to the point, where there's some concern. I know COVID is not a Medicare diagnosis. So what are people's options as opposed to going into the hospital where they might not be able to see their loved one, Jennie? Is COVID something that hospice can help with?
So I'm going to go from the past 8 months, and hospice helped many, many people be comfortable at end of life during COVID. I had, and I was telling you before, 7 to 8 conversations a day during the worst of it with family members, trying to empathize with the decisions that they had to make at that very moment, under duress, in my opinion, right? Yeah. None of us knew what to do. As far as, do we send them out? Do we do this? Do we do hospice? What do we do? All I could do is say, listen, you have a choice. You can send your loved one to the hospital. And I encourage you to call that ER that they're going to go to and have a conversation with them with what's happening right now in their ER, because they're not letting their loved ones in with them. Should they end up with COVID and end up on a ventilator, or however you're going to do it, or if they're going to be in the hospital, they will be alone. They will not have you there. If they stay at home and you have hospice come in, we can make sure they're comfortable and you can have updates. Sometimes they were allowing window visits. Some facilities were allowing one family member at the bedside. Of course, they had to have the full PPE on, the personal protection equipment. It was, I can't even put into words how difficult that was for healthcare workers, families, patients, people working in the facilities, housekeepers, everybody. And I felt like, I don't know if I can do this again.
Oh, amen. Yeah.
Okay?
Yes.
So moving forward, I have the hope, and I have to hold on to that they will treat it better and they'll have things in place. Maybe, hopefully, hospitals won't be overrun. Okay. Hopefully we've gotten that piece. We can only hope under control so that hospitals are not overflowing with patients. But we do need to know with our own loved ones, if this happens, what do you want? Mm-hmm. And if they can't make that decision, have the family conversation. Not everyone is always going to agree on what to do, but they're always going to agree that they want what's best for their loved one. Okay. Different people think what's best is different. Okay. They have a different idea of what's best, but finding the common ground that we all want what's best for grandma or mom or dad or whoever it is, start it that way and always revert back to that, because conversations are very difficult and they can become very emotional very quickly. And with everything that's going on right now, emotions are really high. So it's really important to have those conversations and just talk to your siblings and your family members. Listen, if this comes back with a vengeance this fall, what do you want? How do you want us to handle it? If the hospitals are full, do you want to go there? Most of them will say no. And the problem is we don't want to hear that. We don't want to hear that. Because we know what that could mean, right? So, but understanding what they mean helps us not feel so guilty about having to make that decision, because they've given you the best gift by telling you that.
Yeah, I would agree. And I think that it is, not only is it important to start having those crucial conversations right now. And if you don't know how to have those crucial conversations, I mean, just drop that in the comments below, because there are plenty of ways that we can help you do those little conversation starters, and we can definitely talk about that again. But making sure that you have all of your paperwork in place too. I mean, that's really super important. If you haven't started a medical file on your person, whether it's on your computer in a Google Drop drive, or if you actually are like me and love paper, I love paper. If you're carrying a binder and you've got that binder with you, make sure that you have that somewhere accessible, because again, none of us expected this. And even when we started to put the best practices in place to protect your people in these buildings, it swept through like something I've never seen before. And when emotions are high, rationale is low. Right. So, because you kind of can't have those both. And so you need to plan those things out now. You need to start thinking about those things now. And again, it doesn't matter what's happening here in our world, because our world is very different than inside of those walls where not everybody, but a lot of those people have comorbidities, meaning they maybe have dementia, or they maybe have mild cognitive impairment and hypertension and diabetes and all of those other chronic conditions. And those are the people who are going to be affected. Those are the people that, not just Jennie and I, but every healthcare worker, every executive director, health aide in those facilities, that is our job to keep them protected. And so start having those conversations, start thinking about those things. I think it's really super important. And I know I relied on hospices very heavily these past couple months, and I am so grateful
Mm-hmm.
for people like you, Jennie,
Oh,
who,
well, without you, our jobs would be a lot harder, let me tell you. So
oh,
it's very, it's very important that we as healthcare providers and healthcare workers are supporting each other and feel supported by the community. So that has shown over this whole year, and it does help us feel like what we're doing the right things for the right reason. So not that we need that reassurance, because most of us are
we
here.
do, we
Here, but
do.
it can be very trying. It can
Yeah.
be very stressful. It can feel, very. It can make you think and make you, try to reevaluate. Is this what I should be doing? And then you start to hear feedback from the community and stuff, and it makes you realize that you're right where you need to be.
Yeah.
So,
And it's definitely nice to have that team. You get so busy. Jennie and I both do home care. I do house calls. Jennie does home care, and really reaches out in a different way. And our jobs are very independent.
yes.
I get in my car, she gets in hers, and lots of people that do actual house, like medical house calls like myself. It's a lonely job.
Mm-hmm.
And so I've definitely seen some different team, it takes a tribe. And this tribe kind of came together. It was no longer us against the next assisted living facility against the next one. It was like, oh my God, how do we pull together to get this under control? And it shouldn't just be this way during this pandemic time. It should really be that way always, because ultimately our patients, the community at large of people who have dementia, Parkinson's, and are vulnerable,
Right.
are the people that we need to be teaming up for and looking out for them. And again, Jennie, we couldn't do that without people like yourself who have been given that heartfelt feeling of, this is where I need to be and this is the place where I need to be. So I just want to say I appreciate you. The comments out there, regarding that we got over the last 24 hours, all of them, well, generally most of them were very positive about hospice. Mm-hmm. And I think that today, anybody that had those misconceptions or wrong ideas about hospice, I'm hoping that we cleared some of those up.
Sure.
And I really appreciate your time today. And
my pleasure.
I want to say thank you. Have a good day. Stay safe out there on the road. And I'm sure I'll be talking to you later today.
Thank you all. Take care. Have a great day.
Thanks everybody for joining today. And thank you again, Jennie. I cannot express how grateful I am for the time that you gave us today. If you know somebody who has misconceptions about hospice or questions about hospice, or is considering putting their loved one on hospice, please consider sharing out this video. I know, like Jennie said, this is our journey. This is one journey. It's a difficult journey. And, we'd love to be there to help as much as we can. So if you know somebody that's facing this decision, please share this video out with them and let them know that they are supported. Thank you all for joining today, and I hope to see you again next week. Have a great day.